Hi everybody, welcome to the Code Blue Classroom. My name is Ashley. I'm an ER nurse of 13 years and a nurse educator. Welcome to the first episode of the Code Blue Classroom. I'm excited to be launching the channel. Today's topic is going to be intraosseous access, so join me. The content on the Code Blue Classroom is intended for educational and informational purposes only. While I am a licensed nurse and nurse educator, I am not providing medical advice, diagnosis, or treatment on this platform. Always follow your facility's policies, clinical judgment, and current evidence-based guidelines. The information shared here is not a substitute for professional training, institutional protocols, or medical direction. By watching and engaging with this content, you acknowledge that you are responsible for your own clinical decisions and professional practice. No provider, patient, or education student relationship is established. Any views expressed are my own and do not reflect those of any employer or institution. If you have a medical emergency, seek immediate help from a qualified healthcare provider or call emergency services. Then we have the proximal humeral head in the middle there. Show. Any products that you see in this video today that are branded are not a sponsor of this video, so let's move on. So what is IO access? IO access is access to the vascular system via the bone marrow. I like to think of this like an IV that goes directly into the bone. What sites are going to be used for intraosseous access? This is going to vary by age. So for our kiddos, we're going to be using a couple different sites. We're going to use the distal tibia, which is placed 1 to 2 centimeters above the medial malleolus, which again is a common site in children. We can also use the distal femur. This is used in infants and adults. It's a few centimeters above the knee, just above the patella. As we move into our adult category, we're going to use the proximal tibia. So this is 1 to 2 centimeters below the tibial tuberosity. And it's favored really in all age groups, but it's most commonly seen in our adult group. And on the left side of the screen there, you're going to kind of see the lower leg pictured as emphasizing where that site is going to be. Then we have the proximal humeral head in the middle there. The proximal humeral head is growing in popularity. This site is known for higher flow rates and location. It's a really optimal location for ongoing CPR, especially when you're a sole provider in the back of an ambulance. This goes 1 to 2 centimeters above the surgical neck. Important note, arms should be maintained in a position with the elbow adducted and the palm on the abdomen. So think about having the patient's arm almost like in a sling. You wouldn't, for resuscitative purposes, probably keep the patient's arm in a sling, but there are things you can do to maintain that position. It's important to know also that if that arm goes out of that position, there is a high probability that the IO might actually dislodge or get displaced if the arm is moved. So just note that when you're moving and repositioning the patient. And then the last site is going to be the sternum. This is used in adults, but most often really seen in military and combat settings. The insertion point is on the manubrium, and you're going to utilize a specific needle for this. This isn't going to use a drill. It's going to be a manual insertion device. The way I like to think about the sternal access is, odds are you're not going to have a peripheral access. In a combat or military setting, you might have lost limbs or have significant burns that are going to make this really difficult. So that sternum is really the last site that we're going to be able to use for this. So who needs it and who doesn't? Think of your IO as your bridge to definitive vascular access. So this is not optimal for a long-term sort of placement. Cardiac arrest patients, critical situations when IV access attempts have failed or it's just really not readily achievable, we want to go to that IO so we can stabilize our patient and then look for more definitive access points. We'll also utilize this in pediatric emergencies. So you'll see it respiratory arrest, cardiac arrest, even cases of severe pediatric dehydration where we really just can't get a vein and we need to get some volume in there. We can put an IO in, get that volume repleted, and then look for a peripheral access. The big portion of this slide is going to be those contraindications. So who isn't getting our IO access? contraindications would be fracture in the target bone. This is a big one. So if you have an obvious or known fracture in that bone, we really don't want to put it in there because a fractured bone increases the risk for extravasation. So we're going to get leaking of our medication or our fluid into the surrounding tissues, which the goal for this is to provide those medications or fluids to help stabilize or care for our patient. So if we know it's probably going to fail, the goal is not to really put it there. Then we have previous orthopedic procedures at the site. So you might be thinking to yourself, how do I know? Well, this patient probably is going to have some sort of scar indicating, or maybe family will signify that they've had this. Or if you have access to the chart, you could know that the patient's had these prior surgical interventions. Prosthetic joints or hardware can really interfere with needle placement and also increase the risk for infection. So that's going to move us to the next bullet point here, infection at the insertion site. We really don't want to put a needle through infected tissue because this increases the risk of spreading infection to the bone, causing osteomyelitis. How do we know the patient has a local infection? You're going to see some redness, some swelling, maybe some warmth on that tissue, maybe even leaking if there's an open sore of some sort. The other thing is if the patient's conscious and can tell you, they might have extreme pain or lots of pain at that site. Next, you're going to see bone diseases. So osteogenesis imperfecta and osteoporosis are two disorders that we really optimally don't want to be putting an IO through because it increases the risk for fracture, which goes back to that first bullet point, that fracture in a target bone, not optimal for extravasation. It's really not going to work very well. How do we know these patients have these diseases? Maybe they'll have the medical alert bracelet. If we have access to the chart, we'll be able to see that in the chart as well. And then lastly, burns or significant soft tissue injury at the site. So going back to increased risk for infection, burns are high probability for an increase in a risk of infection. Plus, burns really damage that soft tissue. And when you put an IO in, you really need good needle stability. Otherwise, the needle's going to pop out or it's going to infiltrate. So if there's not going to be that good needle stability with a burn, you're going to again increase risk for infection or extravasation. So it's time to drill. So what is our process? Just a general disclaimer here, the nurse is not performing this skill. This is a physician, advanced clinician, or trained pre-hospital provider skill. As always, just follow your institution's policy and procedures surrounding IO insertion and maintenance. But I find that if I know the steps and the process of a skill, even if it's not my job to do the skill, I'm able to better care for my patients by knowing the process. So on the left here, you're actually going to see the 3 IO needles. You've got 3 different sizes here. So your yellow is going to be your 45 millimeter. This is going to be for patients that are about greater than 40 kilograms, have excessive tissue, or this is an optimal size for that humeral IO that we talked about. Next, you're going to see the blue. This is the 25 millimeter. This is for your adults that weigh greater than 3 kilograms up to that 39 kilogram. Lastly, you're going to see that pink IO needle there. That's your 15 millimeter, which is your pediatric patients. So I always think like pink pediatric. That's 3 to 39 kilograms. And in the next slide, you're actually going to see a little video of the different sizes of the needles kind of up close and personal and what it looks like as they, at the tip where it's going to anchor in. So you're going to prepare your equipment. Oftentimes as nurses, we're preparing equipment for the provider, getting them ready to do whatever skill we're going to do. So it's nice to help prepare the equipment. The provider's going to identify the landmarks based on what insertion site they're going to go with. And then they're going to insert the IO needle either using a drill or a manual insertion device. Just to note that the manual insertion devices do require a little bit more force than a drill. So if you're not a particularly strong person with your hands, it might be a little bit difficult to place. Then you're going to confirm placement. That needle should stand upright. You should be able to aspirate at least a little bit of bone marrow or some blood, and it should flush easily. And then lastly, you're going to secure your device. So you see here the 3 sizes. You're going to see the yellow, you're going to see the blue, and you're going to see the pink. So when we go over the pink, you're going to see here the kind of the components. So you have the stylet, you have the hub, and then you have the catheter. So that stylet is kind of in the left hand there. It's the long piece. This is the catheter that's going to go into the bone, and you kind of see the prongs that help grab onto that bone nicely. And then that hub is where you're going to have your extension set that it gets connected to. This is you would drill into the patient's bone, you would remove the drill, then you're going to remove the stylet, that long needle there, and then you see the hub. Now this dressing here is going to go over top of the hub. You're going to attach your extension set. This is optimally when you're going to pull back to look for that bone marrow aspirate. And then you're going to flush. While you flush, you're going to be looking for signs of extravasation, any sort of signs of infiltration. This may be painful if the patient is conscious, so something to just note that when you flush, signs of pain are not a sign that it's not necessarily working properly. And then you're going to anchor your device down. So those flaps on the side, they peel away and the dressing will stick onto the patient. So what are the nursing responsibilities? How do we manage this thing? Just like an IV, we're going to monitor for signs of infiltration and compartment syndrome. If there's signs of infiltration, you're going to see, similar to an IV, it's going to be cool to the touch, swollen, it could be red or pale. You might see swelling or leaking of the fluid kind of coming out around the site itself. You might notice that if you're infusing something, the flow rate might be slower, it's harder to push through. And then we're going to look for signs of compartment syndrome. This might be observed with more prolonged use, which again is not optimal, or as a sign of a problem after you've had the IO in, or even removed. If there was any sort of trauma there, you might observe signs of compartment syndrome. So pain that won't go away with pain medication, swelling, really disproportionate pain is going to be one of those big things that we'll see. So again, we're going to assess the site in conjunction with our monitoring. We also really want to advocate for our patient and provide pain management. So this is not a comfortable procedure. If your patient is awake, the actual drilling itself is reported to not be horrible. It's when you go to infuse something through it that's very uncomfortable. So again, follow your site's policy and procedure, but many providers are going to order some sort of intraosseous pain medication, or you can even instill some like lidocaine in there that will help numb it and make it a little more bearable for the patient. And lastly, we're going to document. So just like anything we do in nursing, we really need to make sure that we're documenting really thoroughly the size, site, how it looks afterwards, if we're infusing things through it, and any complications that we notice. Lastly, let's talk about some complications. So extravasation, we've kind of talked about this repeatedly throughout. So extravasation is leaking of fluid into the surrounding tissue. We're going to see that. We might also see compartment syndrome as a complication. A big one I want to talk about is growth plate injuries though. So if we're putting IO in children, there is a risk that when we drill, we could drill into the growth plate. Location of our drilling, the goal is to try and avoid those, but if it happens, it can significantly impact the child's growth later, so something to just be cognizant of. And then lastly, drilling into a bone can always cause fracture, so if the patient has an unknown disorder like osteoporosis, we could in theory fracture, or just weakening bone, we could fracture that site, which isn't something we would know about until later. And that about does it for this video. Thank you for tuning in. If you like this video, please give it a big thumbs up, subscribe to this channel, and leave a comment down below with what videos you would like to see next. Knowledge is your best code card. Stock it well. See you next time.